I would like to invite Dr. Richa Gupta to initiate our first session. Over to you, Doctor.
Yeah, hi, good morning. Where's the video not starting? Just a minute. Right, is it visible and am I audible?
Yes, ma'am, please go ahead.
Yeah, right. So very good morning to you. Secondary glaucoma refers to any form of glaucoma with an identifiable secondary cause, resulting in optic nerve damage and vision loss. It is notorious for being aggressive and more resistant to the regular line of management, and clinicians have to resort to augmented surgeries and treat the primary pathology. Otherwise, permanent vision loss is inevitable. Today's session aims to apprise our general practitioners and residents in a concise manner and provide an understanding of this condition. So let's begin our instruction course for the day. The first talk is on neovascular glaucoma. Right, so what is this disease? It's a potentially devastating sequelae of serious underlying ocular or systemic disease, which is mostly ischemic in nature and causes neovascularization of the iris, which is called as NVI, or neovascularization of the angle, which is called as NVA, that ultimately leads to neovascular glaucoma. So the synonyms which may be used by few of the people are hemorrhagic glaucoma, thrombotic glaucoma, rubiotic glaucoma. There are a lot of predisposing factors which are there, like you can see the list, the huge list of the diseases, but we'll concentrate on the top 3 causes of NVG, namely the diabetes mellitus, which causes around 30 to 70% of NVG cases, retinal vein occlusions, which accounts for 20 to 36% of NVGs, and carotid occlusive diseases, which accounts for 2 to 13% of NVG. So let's come to the first most common cause of NVG, which is diabetic retinopathy. So it accounts for approximately 1/3 of the cases, and there is a high prevalence with proliferative diabetic retinopathy. Next comes the CRVO. So NVG is more commonly seen in ischemic CRVO vis-a-vis non-ischemic. And the study demonstrated, CVOS study demonstrated a conversion rate from non-ischemic to ischemic in around almost 1/3 of the cases. And that is why it is very important to follow up the patients closely over time to monitor for early signs of neovascularization. The third one is carotid artery obstructive disease. So a low intraocular pressure in the setting of an NVI and NVA should raise a suspicion of carotid artery obstructive disease. So especially if there is low IOP in the absence of a retinal detachment, if there is a gross asymmetric diabetic retinopathy, and if there's a persistent NVI even after PRP. If there is an unidentified etiology for NVG even after a full ocular examination. So all these conditions should raise a strong suspicion of carotid artery obstructive disease. Prompt diagnosis and treatment can save not only the eye, but also the patient's life. And that is why it's a very, very important entity to be kept in mind. What's the pathophysiology of the disease? So any kind of ischemia, retinal ischemia, causes reduced perfusion or non-perfusion of retina. Hypoxia is created, and there is a release of vascular endothelial growth factor, which causes pericyte activation, endothelium proliferation, and in return causes angiogenesis. Important points to be kept in mind is the lens vitreous act as mechanical barriers and also release vasoinhibitory factors. So any breach of the posterior capsule, which may occur in 2 conditions, either you can have a complicated cataract extraction or a capsulotomy, laser capsulotomy. This allows angiogenic factors to gain access to the anterior segment, accelerating the neovascularization of the anterior segment. So So what do we get in the examination? Detailed history in a patient with elevated intraocular pressure and comprehensive ocular examination for neovascularization, especially in patients where the eye is predisposed to NVG, needs to be done. Particular attention is to be given to the pupillary margin, and it is to be examined under high magnification. Angle structures need to be seen, and there has to be a detailed dilated fundus examination. A non-dilated gonioscopy is an easy, cost-effective, and quick office procedure for early detection of NVA. So let's come to the stages of neovascular glaucoma. This is the first one where the neovascularization has occurred, and it is formed from the minor and major arterial circle. There is a fibrovascular membrane, which is nothing but actually a histological membrane, not visible clinically. If it progresses in the second stage, the membrane crosses over the trabecular meshwork, causing its obstruction, and thus the IOP rise follows. This is the open angle stage. And when this membrane contracts, it forms a zippering of the angle, pars formation, and this is the angle closure stage. So let's look at each stage carefully. So stage 1, as I told, is the Rubiotic stage, where there is neovascularization, but the patient is asymptomatic because the intraocular pressure is normal. So NVI, the neovascularization of the iris, may be seen as fine, arborizing or branching, superficial, and leaking vessels, especially near the pupillary border. So the left side photograph shows pupillary border NVI, and the right side photograph shows NVA, which is neovascularization of the angle. So as I told, when this progresses, if the treatment has not been given in the first stage, the membrane, it blocks the trabecular meshwork. So there will be increased NVI and NVA. Now the IOP starts rising, and there will be anterior chamber inflammation. There may or may not be hyphema. Still, the angles are open. There is no peripheral anterior synechiae. Histologically, there may be a fibrovascular membrane which may be elicited. So this covers the angles and obstructs the aqueous outflow initially. So what happens in the third stage? As the disease progresses, the proliferating myofibroblasts of fibrovascular membrane contracts, and this leads to ectropia on UVA, peripheral anterior synechiae, and total angle closure. And this is how it looks. The top photograph is of ectropia on UVA, and the lower one is a total zippered angle. So most of these patients are detected in this stage. Why? Because now the patient will be symptomatic, the intraocular pressure will be very high. Unfortunately, this is not reversible by PRP. The resultant glaucoma is often refractory to the management and mostly requires surgical treatment. So again, the clinical features, the patient will come with severe pain, headache, vomiting, redness, watering. There will be decreased vision and photophobia. And when you examine the patient, there will be a reduced vision and ciliary injection, corneal edema, hyphema may be there, NVI, NVA may be there, and there will be fixed dilated pupil with a raised intraocular pressure. What are the investigations which need to be done in neovascular glaucoma patients? So in the ocular investigations, the first and foremost is the fundus fluorescein angiography. This is basically to assess the retinal ischemia. ERG may be done. Again, it tells us about the retinal ischemia, not routinely done. Iris angiography, again, is not routinely done, but can be done in doubtful NVIs. Ultrasonography is done if the retina is not visible, just to assess the posterior segment. Systemic evaluation is important for diabetes. If the patient is not a known diabetic, then investigations need to be done. There may be a carotid Doppler, which may need to be done in patients where we suspect OIS or ocular ischemic syndrome. Lipid profile and renal profile will need to be done. So coming to the treatment, what are the main two objectives? The first one is to identify the etiology, because that is the reason why the patient has developed neovascular glaucoma, and it's timely and adequate treatment to prevent the development and progression of the disease. And the second objective is to control the intraocular pressure. So this is done to prevent the optic nerve damage and treat again, it goes in concurrence with the first point. So this is a preventive measure, pan-retinal photocoagulation. It's the procedure for choice for ischemic retinal disease. and it has been shown to reduce and eliminate anterior segment neovascularization. It usually reduces or stabilizes the intraocular pressure in open angle and may improve the outcome of filtration surgery preoperatively. PRP should be performed at the earliest sign of neovascularization. So the anterior segment, consultants should send the patient for a vitreoretinal consultation. So how does PRP work? It makes the ischemic retina anoxic, thereby decreasing the angiogenic factor and decreasing new vessels, and thus reduces the anterior segment neovascularization. So 1200 to 1600 burns are usually given, approximately 500 micron spot size, one spot apart, ideally completed in 1 to 3 sessions over a period of 5 to 7 days. So in diabetes, if there is established PDR, PRP is combined with intravitreal anti-VEGF to prevent NVG. The patient needs to be under a close follow-up. In cases of CRVO, PRP is indicated only after 2 clock hours of neovascularization as per the study. And in ocular ischemic syndrome, it is indicated for cases with retinal ischemia on FFA. A very important point is a neurological and cardiology assessment is required. In cases where PRP cannot be performed because of media opacity, panretinal cryotherapy or transscleral diode laser retinopexy can be used for retinal ablation. Another option is to use endolaser or indirect PRP during pars plana vitrectomy and, if needed, lensectomy. Gonio-photocoagulation is only an adjunct to PRP. It does not eliminate the vascular angiogenesis. So it is aimed at directly treating the NVF before the development of NVG and has no role once the glaucoma has been established. The medical management includes mostly the aqueous suppressants. Prostaglandins will not be effective if PAS has developed because it limits uveoscleral outflow and also increases inflammation. The same is the case with myotics, which is actually contraindicated because it can increase the discomfort and inflammation. Topical steroids and cycloplegics are added. Osmotic agents may be given if the intraocular pressure is very high. And if corneal edema is preventing PRP, then topical glycerin may be applied. Anti-angiogenic drugs like bevacizumab, intravitreal or intracameral reduces angiogenesis and reduces inflammation, especially preoperatively. So in advanced stage where synovial closure has ensured, surgical intervention for intraocular pressure lowering is often required. And usually these are the 3 surgical parameters which are used. First is trabeculectomy, second is tube shunts, and the third is cycloablation. So the success rate of trabeculectomy with mitomycin C at 1 year was studied by Takihara et al. And it has been reported to be 62.6%, which reduced to 51.7% at 5 years. So you would notice that the success rate is a little lower. It is usually complicated by intraoperative bleeding and progression of the membrane postoperatively. So with the use of, as I told, preoperative bevacizumab, success rate may improve up to 95%.
Sorry, ma'am, can we wind it up in next 30 seconds, please?
Yes. So antifibrotic.
Ma'am, you are not audible, ma'am.
Richa, you're not audible.
Ma'am, you're not audible.
Hello?
Hear you, Richa. We can't hear you.
AV, can we please have some help on this, please?
मैम मैं उसमें वो सुनी मैं कैसे कर सकता हूँ मैसेज भी कर दिया उनको रिप्लाई नहीं कर रहे हैं Ma'am, you are not audible.
Am I audible now?
Yes, you're audible. Please go ahead.
Yes, audible.
Dr. Richa, you're audible now. Please go ahead.
Can you hear me now?
Yes, ma'am, we can. I think there's some technical issue from their end. We will continue with our next speaker. I would like to invite Dr. Swarnali Sen. Ma'am, if you're here, can we start with your presentation?
Good morning. Am I audible?
Yes, ma'am, you are. We can't see you.
Yeah.
Yeah. Ma'am, please start with your screen sharing.
Hi, am I audible now?
Yes, ma'am. You'll have to start with
Samruddhi,
the
are you
slideshow.
there?
Yes, ma'am.
Okay. Are my slides visible?
Yes, ma'am. You can go ahead.
So a very good morning to everyone. Today I'll be speaking on pseudo-exfoliation glaucoma. So before I go into the topic, I will be sharing a small case of a patient whom I had seen just a few days back. He was a 60 years old gentleman who presented with a gradual diminution of vision excuse me, in the right eye and pain in the left eye for 2 years. On examination, his best corrected visual acuity by 6 by 36 and 48 in the right eye and 6 by 9 and 6 in the left eye. On anterior segment examination on slit lamp, the anterior segment was found to be normal in the right eye except for an early cataract. But in the left eye, a relative apparent pupillary defect was noted and the intraocular pressure was high. It was around 38 millimeter of AJ on Goldman applanation tonometry. Moneoscopy was done, which revealed open angles. The patient was dilated and to examine the fundus. And it revealed that in the right eye, the cup disc ratio was 0.4 with a healthy neuroretinal rim. Choroidal neovascular membrane was seen at the macula in the right eye, which explained the low vision in the right eye. But in the left eye, the cup disc ratio was 0.8 with a bipolar notch and a significant pallor in the disc, but the macula was healthy. So this explained the RAPD, which we observed in the left eye. But when we re-examined the anterior segment on slit lamp on dilation, a subtle finding was noted on the anterior capsule, a fine membrane on the anterior capsule. And as we can see in the picture, it was pseudo-exfoliation. So this gave us the clue to the diagnosis of unilateral glaucoma in this patient, so we went ahead with the OCT as expected. The optic nerve it showed severe damage and the visual field which showed advanced field loss in the left eye. The right eye was not done because of the macular pathology. So here we have a patient with unilateral severe glaucoma at presentation. So keeping the short case in mind, we'll go ahead with the presentation. So pseudo-exfoliation syndrome, as we all know, is an age-related systemic microfibrillopathy caused by progressive accumulation and gradual deposition of extracellular gray and white matter over various tissues of the body. The material is deposited in different structures of the eye. Increased risk of development of glaucoma and cataract are the most common conditions which raise concern among these patients. Now coming to pseudoexfoliation glaucoma, it is considered to be the most common form of secondary open-angle glaucoma. Although the condition is mostly bilateral, it is usually asymmetric, and that's why unilateral presentation is common. It has been found to have a worse prognosis than POAG due to higher fluctuations in intraocular pressures and a more severe optic nerve damage and visual field changes. Hypothesis is that the optic nerve has an intrinsic susceptibility to intraocular pressure damage because of the extracellular material deposition on the optic nerve. These patients also tend to have usually higher levels of intraocular pressure than those with POAG. Now coming to the epidemiology, the reported prevalence in different parts of the world varies from 0 to 38% in different populations, and the prevalent rate of the syndrome in glaucoma patients around 0 to 93%. The prevalence increases with age, and high prevalence is noted in patients between 60 to 70 years of age. So what is the pathophysiology? Pseudoexfoliation glaucoma mostly is open angle. So it occurs due to accumulation of pseudoexfoliative material on the trabecular meshwork, leading to its obstruction and rise in intraocular pressure. However, in some cases, angle closure glaucoma or mixed mechanism glaucoma is also found, which is mostly due to zonulopathy leading to forward displacement of the lens. This is because of the pseudoexfoliative material getting deposited on the zonules. May also occur due to progressively maturing cataract, which causes narrowing of the angles. Now, diagnosis is essentially clinical. A meticulous slit lamp examination, including gonioscopy and pupillary dilatation, is considered to be the gold standard. Coming to intraocular pressures, usually these patients, as I've already said, usually present with very high intraocular pressure and show a wide range of IOP fluctuations. On slit lamp examination of the cornea, there may be presence of pseudoexfoliative material or pigments on the corneal endothelium. A decrease in number of endothelial cells and increase in guttae have also been noted. The anterior chamber may have a shallow depth. On examining the iris and the pupil, there will be deposition of whitish flakes on the anterior posterior surface of the iris and at the pupillary margin, which might show a moth-eaten appearance and have transillumination defects. In most cases, there is poor or absent pupillary dilatation as a result of atrophic and fibrotic changes in the iris sphincter muscle. And these patients usually tend to have a more rigid pupil. Gonioscopic, most of these patients have open angles. Pigments and flakes of pseudoexfoliative material can be observed over the structure of the angle. A particular pattern of pigment deposition on the Schwalbe's line is called Sampaulis's line. However, some patients may present with narrow and closed angle glaucomas. On the lens, we find a classical pattern called the Bullseye pattern, in which the flakes of pseudoexfoliation material are deposited on the anterior lens capsule in 3 distinct zones. Usually the central zone corresponds to the pupillary diameter. There is an intermediate clear zone due to rubbing of the iris against the anterior lens capsule, and the most peripheral radiating zone. Phacogenesis due to zonular weakness and lens subluxation may be noted. The optic disc evaluation often shows severe disc damage and some amount of pallor in some cases, as ischemic changes in the retina and optic disc have been reported due to deposition of this material on the vascular endothelium. Asymmetry in the disc is noted in unilateral cases. Though the diagnosis is mainly clinical, ultrasound biomicroscopy can be done in cases with suspected zonular weakness and lens subluxation to find out the degree of weakness. Coming to the management or treatment, of course, medical management is the first line of treatment for these patients, and initially they show good response to medical treatment, that is the topical anti-glaucoma medications. Prostaglandin analogs seem to be the initial drug of choice, not only because they cause higher lowering of IOP, but also have a longer duration of action and a better control of the diurnal variation and the IOP spikes. However, these patients in many cases become refractory to medical therapy. Lasers have also an option. Laser trabeculoplasty, ALT, SLT have also been tried in these patients and have seemed to produce a better response than in POAG due to diffuse pigmentation of the trabecular meshwork. YAG peripheral iodotomy is effective in mixed mechanism and angle closure glaucomas. Surgical treatment is the option in cases where the patients have become refractory to medical therapy or they do not respond to laser therapy. Trabeculectomy is the surgery of choice in these patients. Glaucoma drainage devices, and often trabeculectomy have to be augmented with antifibrotic agents. Glaucoma drainage devices are used in cases where there is a failed trabeculectomy before or some other surgeries which have led to conjunctival scarring. Cataract extraction or a combined surgery, that is cataract with a glaucoma filtration surgery, gives good results in patients with narrow or closed angles. So I would like to conclude that pseudo-exfoliation glaucomas are often severe and progress rapidly. Meticulous slit lamp examination to pick up subtle signs of pseudo-exfoliation can lead to early detection of the disease. Aggressive management of glaucoma with proper monitoring can prevent progression and blindness in such patients. Thank you.
Thank you, Dr. Sonali. Am I audible now? Yeah,
Yes,
I'm so
ma'am.
sorry for the technical glitch, and I was like almost at the end of the presentation. There was a treatment algorithm. We'll see if there is time. We'll go back to it. So I would like to ask the panelists one question. So in such patients of pseudoexfoliation, how often have you had to use, a CTR, or how often have you seen a ZD during cataract surgery? Dr. Manish, would you like to take that up?
So basically, for any patient with pseudo-exfoliation, always look for angle closure. So that will give you some amount of idea whether the zonules are a little more lax. Good clinical evaluation is necessary before you take up any sort of pseudo-exfoliative patient for surgery. Especially look at the dilatation and what sort of maneuvers are required during the surgery. But many people use a CTR, be ready for a CTR in the sense that when you're operating any patient with pseudo-exfoliation, be ready for a greater chance of surgical complications. But I don't think that it is that common that I need to use a CTR in every second patient to do something like that. And probably in a few couple of patients, you may require that sort of an intervention. I don't find it very, very often that I need a CTR for these patients. I'm able to manage it without that.
All right. Dr. Swarnali, I had a question for you. So in unilateral presentations, how important is it to actually look at the other eye?
Actually, what I've already said, that the condition is usually bilateral. Since it's asymmetric, we get unilateral cases. So it is definitely important to monitor the other eye to pick up the late development of signs of pseudoexfoliation or glaucoma. So when we are monitoring the affected eye, we should always see the other eye and monitor it closely as we are doing the affected eye.
How closely do you monitor them? What is your follow-up protocol?
It depends actually how the IOP is being controlled, how much the patient is, whether the patient is progressing or the patient is stable, is showing signs of progression. So it depends on how the affected eye is doing. So, so at every visit, we should not neglect the other eye. We should also give a proper attention to the normal eye, the other eye, the unaffected eye.
Right. Thank you, Dr. Sonali. We'll move on to the next speaker, who is Dr. Ravi. He was earlier a faculty at Shankar Nethralaya following glaucoma fellowship at LV Prasad Eye Institute, Hyderabad, and currently is associated with BBI Eye Foundation VIP as glaucoma consultant. And today he will be discussing on traumatic glaucoma. Dr. Ravi, please.
Good morning, everyone. At the outset, I would like to thank Dr. Richa for having me as a part of this IC. Thank you, AIOS, for organizing such a nice digital conference this time. Am I audible? Are my slides visible?
Yes, sir.
Thank you. So traumatic glaucoma, I have no financial interest in this presentation. It has a very wide spectrum, But first, before we go into the details of traumatic glaucoma, let's understand why do we get glaucoma in case of injury. The moment we have an injury, the first part of the eye to take the burnt is a cornea, and we get some sort of indentation. Sometimes there may be a tear. In case it skips a tear, the maximum force is passed on through the angles, and this is the area which bears maximum burnt of trauma. Also, iris, there can be changes in the iris, and zonules can be affected. Sometimes lens displacement, dislocation, or breach in the capsule of the lens can take place. So all these structures like cornea, angle, iris, zonules, lens, these are the main structures which bear the brunt of trauma. Sometimes there may be vitreous hemorrhage or involvement of retina, but in those cases, the prognosis is really very bad. So once we are looking at a case of traumatic glaucoma, we need to look for changes in the conjunctiva, like any signs of conjunctival tear, or any changes in the underlying sclera, changes in the cornea. If it is possible, if it's a closed glove injury, we can go and check the intraocular pressure. Our main focus should be to look at the iris changes and angle changes if the situation permits. If we are able to do gonio, we can go ahead and do. Otherwise, it would be ideal to wait for some time. And we should look for hyphema if it is present. The presence of hyphema indicates that definitely the trauma is of some significance. We need to look for lens displacement, if any. And in case the visibility is poor, we need to do a B-scan ultrasound to get an idea of what exactly is happening inside the eye. Now, I would like to go for a case-based discussion based on what regular cases we see in our OPD. Coming to the first spectrum of cases, like these are simple cases, like say this 14-year-old boy who was injured with a cricket ball with minimal contusion injury. And this kind of injuries we usually treat with antibiotic steroids. And if required, the pressures are on a higher side or say borderline, we add one anti-glaucoma medication, say a beta blocker or so. And I usually defer the gonio examination for 1 week if the patient is not cooperative on day of examination. In this case, with one anti-glaucoma medication, the pressure was almost borderline to normal range. And these cases usually do not require surgical intervention. I follow these patients at 4-monthly interval for 1 year and thereafter on yearly basis. Now, in a more difficult situation like a major trauma, a 16-year-old male was hit with a cricket ball. His pressures at presentation were very high, 34 millimeters of mercury. Initially, we started treating him medically with antibiotic steroids, AGM, and this particular injury was repaired. In follow-up, we saw that even with like maximum possible medication, his pressures were on the higher side. And we could do gonio after 1 week, which showed no obvious angle recession. Even he had a severe injury, but somehow the angle structures were spared. Ultimately, for high IOP, he required TRAB, and the pressures were controlled after 2 months. We waited for some time. We continued the medications, hoping that the pressures will come down. Once it didn't come down, we went ahead with TRAB. Now, this is a common scenario that we have. Another 21-year-old male who was hit with a stick, and what we saw was anterior segment was largely okay, except for the hyphema which was present in the anterior chamber. So we treated him medically with tapering dose of steroid, antibiotic, and with cycloplegic agents. Over a week's time, hyphema resolved, and his pressure was almost in the acceptable range. And since there was no angle recession, we kept him on observation 4-monthly for 1 year. Hyphema can have a spectrum of presentation. It can be very less minimal hyphema, which we can absorb. Sometimes it is say up to 50% of the anterior chamber, wherein we can consider drainage. In other situations, it can be almost full chamber hyphema, also called 9-ball hyphema. In these cases, they could be associated bleeding in the vitreous cavity also. And the pressures will definitely be high in these kind of cases. So anything above 50% of total hyphema, we have to consider that pressure will be high, and glaucoma procedures, some sort of intervention, glaucomentation will be required. And in 30% cases, there can be a rebleed. If we see this picture, we can understand that he had at least 3 episodes of bleeding in the anterior chamber. And if there's a full chamber hyphema, if the hyphema is not resolving in 1 week's time, there might be chances of corneal staining. So this we should keep in mind. So whenever we have a situation like this, within 1 week, we should consider going for an AC wash, and especially if the pressures are above 25 millimeter of mercury, there's no point in waiting for even a week. We can go for early intervention also. If ultrasound shows vitreous hemorrhage, then possibly we have two options. If we can take help of our retina consultants and plan for a combined vitrectomy also, if it is a persistent high IOP with thick blood in the vitreous chamber, or if you think that the vitreous hemorrhage is not much, then we can go ahead with the anterior chamber wash with trabeculectomy. Again, trabeculectomy is a bit controversial, but if there is a severe damage, then it is better to go ahead and do trabeculectomy if the pressures are in very high range. Now coming to another case of trauma, like this 34-year-old male had a road traffic accident. If we see carefully, you'll see that there is iridodylisis in this part, and he had hyphema, irregular pupils. There was iridodylisis at 9 o'clock position, and angle recession from almost 10 o'clock to 4 o'clock. Almost 12 hours of angle recession was noted. What happens in these cases is blood, plasma, and other debris, they tend to clog the trabecular meshwork. Also, there is injury directly to the meshwork, also causing inflammation. And this injury can, in a later stage, cause a scarring. So overall, initially, the IOP is high because of inflammation and debris. And in the later stage, the trabecular meshwork doesn't function that well, leading to high IOP. Now, this patient, we started on anti-glaucoma medications, his pressures were controlled with 4 medications initially. And when we have angle closure, once the inflammation is well controlled, when there is less of reaction, then we can consider starting prostaglandin analogs also, because this medicine increases uvascular outflow. So normally the use of prostaglandin analogs is controversial in the initial phase, but once the inflammation is less, we may consider this because it is effective in IOP control. There are 2 IOP spikes in case of injury. Initially, for first 1 year, there can be episodes of ups and downs. And later, when the patient completely forgets about the episode of trauma, there can be another spike, say around 10 years later. So for these patients, a close follow-up or yearly follow-up for a lifetime is advisable. I would just like to explain what exactly happens in case of angle recession. Here, if you see this patient, the iris is attached to the ciliary body exactly at this point. But from here, we see angle recession. If you see carefully, it's like a split of the ciliary body muscles. So at one part, we can see one group of muscle. On the scleral side also, there is a muscle fibers which are attached on the scleral side also. It's something like a split with muscles on both sides, and we see that the angle is deep. Now, coming to a case of cyclodialysis, this is a 34-year-old male who was a football player who had injury on field. He presented with high IOP and pain. His AC depth, his AC was quite deep at presentation also. When we could do examination of gonio, we saw that if you see here, like you will see that there's a whitish area here, which represents earlier attachment of ciliary body here. So the entire ciliary body has receded back because of the impact of the injury, and AC is quite deep, and this is called cyclodialysis. So he had both in the temporal side, he had angle recession, and on the nasal side, there was cyclodialysis. Now, these two factors have opposing effects. Angle recession leads to high IOP because trabecular meshwork is not functioning well. Cyclodialysis sometimes can lead to low IOP because the aqueous gets a channel to pass through the uvascular channel. See, if you see here, this would be the normal angle. Here, because of recession, and here you see increased passage or almost a tunnel kind of a structure because of cyclodialysis. So because of these opposing factors playing a role in the same eye, the patient was stabilized just on one anti-glaucoma medication. Now, another spectrum of case, the patient had an injury with a hammer, and when he presented, the lens was at the pupillary border. We didn't realize that the lens had totally got dislocated. His IOP was high, and for evaluation, we dilated him. The moment we dilated, the whole lens was in the anterior chamber. So this was a case of traumatic lens, initially subluxation, but in clinic, it became dislocated. So in these kind of cases, the only option is to go ahead and remove the lens. The patient was ultimately stabilized on 2 anti-glaucoma medication, and later we did SF-IOL with TRAB for him. Now, initially, in some cases, there might be AC shallowing following trauma, and we can try. If the lens is clear and reasonably well supported, the PI may help and the glaucoma may be under control. But if there is a significant cataract, as in this case, the only problem that this patient had was intumescent lens. In these cases, we have to go ahead and operate and remove the lens. In lens-related glaucoma, sometimes there can be blockage of the trabecular meshwork because of lens particle release. It is best to avoid anterior chamber lens or iris fixated lens in these cases, and it's better to prefer either a capsule or bag IOL implantation or to go ahead with scleral fixated IOL based on the situation on table. Now, last few slides only. So this case was an open globe injury. The patient hit with stick. There was a corneal tear. In fact, I would say corneal tear only. If it is not involving sclera, is a good case. There are chances that if it is well repaired, the glaucoma chances would be less. These cases may escape secondary glaucoma. Now, in these cases where we have iris prolapse, it's damage to the sclera also or the limbus, there are high chances that secondary glaucoma will happen because of mechanical damage to the meshwork initially, and the inflammation may cause scarring of the trabecular meshwork later in life. The method of following these cases would be initially watertight closure and foreign body removal to prevent fibrous ingrowth and epithelial ingrowth. Here, if you see, there is the ingrowth of endothelial tissue, of epithelial tissue, which is very difficult. Secondary glaucoma caused by these cases are very difficult to treat. So in these cases, if required, we can go ahead with trabeculectomy augmented with mitomycin or Ahmed glaucoma valve. But many of these cases do proceed to the stage wherein cyclodestructive procedure is the only option. But it would be ideal, or it would be very important to remove the foreign body if any is suspected. The last category of cases in my presentation is chemical injury. If the patient presents with chemical injury, initial management is just to treat the high IOP spike, but sometimes the IOP can be low also because of ciliary shock. But in later stage, definitely the IOP will go up. And we have to remember that there would be a good amount of conjunctival scarring, and these cases trap may not work. So for these situations, it would be ideal to go for a tube surgery or to prepare the patient for cyclodestructive procedure. So in conclusion, I would like to say, initially, we should try to control the patient's symptoms and attempt medical control. We should buy time, delay the surgical procedures as much as possible. But still, in any case of trauma, we should be ready for surprise. On table, there can be sudden dislocation of lens, AC shallowing, rebleed, and we should inform the patient regarding these management concerns beforehand only. And the patient should be informed that he will require lifetime follow-up, as there is a bimodal presentation, many cases present years later. Thank you. Thank you very much.
Thank you, Dr. Ravi, for this wonderful case-based discussion. So you've answered actually many questions which a general ophthalmologist or a resident may have in their mind in cases of trauma. So again, reinforcing the thing, first one is the difference between cyclodialysis cleft and angle recession, which has been elaborately talked about by Sir. And second is prostaglandin analogs have to be started once the inflammation subsides. Right. So there is another question, sir, which is actually asked very commonly. How early can we plan a gonioscopic evaluation in a case of traumatized eye?
It would depend upon how exactly the situation is. Suppose I have a patient who is comfortable, the initial few cases that I had shown, then if the patient is, like, say, adult who understands the situation, we can do it on the same day if the epithelium is okay. But in case there is a problem, if you're thinking that the epithelium is there is a problem with the cornea or epithelium, or you're suspecting any injury in the backside of the eye, I would say defer it at least for a few days. I would usually call the patient after 3 to 7 days based on situation. And within 1 week, I would attempt a gonio procedure.
Right. And would a presence of hyphema,
in case there is a hyphema, delay it till the till hyphema resolves, or take up a procedure to clear hyphema. Once we clear hyphema, again 3 to 7 days, because chances of rebleed from the same point will be there. So if hyphema is there, again we can delay it for 3 to 7 days.
Right. And another point was how often, like you've said that the IOP may rise even after 10 years of trauma. So how often and for how long do you follow up these patients?
Okay, I'll just narrate about one case. I had one army officer who came to me after retirement. So retirement, I would say, if it would be after 50 years of age, and we found that he had traumatic glaucoma. And when we tried to dig in and take the history, he told that during his marriage, he had an injury with a shuttlecock. So injury with a shuttlecock in the right eye during marriage, and glaucoma presents at the time of retirement. So
Okay.
it's like a teaching lesson for us. It can present
Really?
at any time. And I would request that if you see a case in which there is some amount of damage, angulization and all, at least the patient should be guided that he needs an annual checkup. Whether he will do or not, it is a difficult question to answer. But patient should be told that you can develop it anytime.
Right.
At least from the medical legal point of view.
Right, sir. So another interesting entity is development of hypotenuse maculopathy secondary to a cleft, a cyclodialysis cleft. So what is your management, algorithm? How do you manage such patients?
Initially, that attempt is to try to treat medically as much as possible, because in most of the things like glaucoma, the things tend to improve over time. So at least for a few months, we try to observe, try with medical therapy, atropine. If it works, fine. If it doesn't work for a few months, say I wait for 2 to 3 months. If it works, fine. Otherwise, we'll go for a repair. We try to suture the cyclodialysis cleft, try to repair it. Usually it works. I've seen during my fellowship days, I've seen my seniors doing 3 cases of cyclodialysis cleft repair, and luckily all 3 of them worked.
Right. What about laser therapy for cleft closure?
I have no experience of laser therapy in these cases.
Right. Anybody else on the panel? Manish sir, would you like to?
Some cases have
So actually,
Yeah, Dr. Pallavi.
cyclocryo and laser. Some cases in the literature.
Right.
So it depends on the size of the cleft also. So if the cleft is small, it is likely to close with laser. So that may be one of the indicators. The cleft is very large, it's not likely to close with the laser. Usually less than 2 clock hours, possibly you can give a chance for a laser, and you can use cycloplegics and see whether it's helping, or you can repeat the lasers for a certain period. If it's large and it's not working out well and you've waited for some time, yes, definitely you have to go for surgery.
How long do you wait, sir, for taking up the patient for laser therapy?
Laser therapy, I'll wait till all the initial inflammation subsides a little. And what I mean to say is that is there any hyphema or there's something else there, then wait for that period of time till I'm able to see that area clearly. After that, I can have to incite inflammation in the eye, and that is the reason I'm doing the laser.
Right, so thank you so much. Thank you so much, Dr. Ravi, for the elaborate presentation. So we'll move on to the next speaker, who is Dr. Pallavi Raj, who is a very close associate of mine. She completed her glaucoma fellowship from Shankar Nethralaya, Chennai, and is currently working as a senior consultant in the glaucoma department at Shankar Nethralaya, Kolkata. Today, she will be throwing some light on uveitic glaucoma. Over to you, Dr. Pallavi.
Is my screen visible?
Yes, we can see you. We can hear you well.
Okay, so a very good morning to all my colleagues. First of all, I would like to thank AIOS for this opportunity, and also Dr. Richa Gupta for having us do this IC along with her. So I'm going to talk about uveitic glaucoma. It is different from other types of glaucoma as it is episodic. It is partially iatrogenic. It has very high IOPs, and if untreated, it can have rapid progression. So what are the factors that influence IOP in uveitis? There are factors which lower the IOP, and there are factors which increase the IOP. So factors that lower the IOP are cyclitis, because it decreases the aqueous humor production, and PG release, because it increases the uveoscleral outflow, so the IOP may decrease. And the factors which increase the IOP are like influence of cytokines, increased viscosity, increased trabecular meshwork resistance, corticosteroids, and this is because of the decreased PG mechanism. There may be pigment deposition, and some cases may have angle closure with raised IOP. So here we can just see what are the mechanisms of glaucoma in different types of uveitis. So anatomically, if there's anterior uveitis, FHI, lens protein uveitis, Posner, they will have open angle mechanism. HLA B27 and JIA, they will have closed angle or steroid-induced mechanisms. Pan uveitis will have ARN masquerade sarcoidosis, viral, they will have open angle. whereas VKH and sympathetic ophthalmia may have closed angle or steroid-induced mechanism. Posterior uveitis like toxo will generally have an open angle mechanism. So going into the detailed mechanisms, so if it can be open angle glaucoma, example like JIA, FHI, and the pathophysiology is obstruction of the trabecular meshwork by cells, debris, fibrin, protein. This is all because of increased blood aqueous barrier permeability. RO kinase and PGs, they increase outflow resistance by decreasing the outflow facility of the trabecular meshwork. Trabeculitis can also occur in acute viral uveitis syndromes like herpetic, Posner, and even in sarcoid, syphilis, and toxo. So here, basically, there is inflammation of the trabecular meshwork, thick and edematous trabecular bands, fibrin and inflammatory cell infiltration, which obstruct the outflow channel. Now, important thing to remember in this is, which makes it different from this, is that the AC protein content in these situations is low. So these patients will have very high IOP, but the protein will be low. So this is basically trabeculitis in opposition to open angle glaucoma, which has high protein content in the AC. Some of the other mechanisms can be steroid use and angle closure. So going into the details of steroid-induced ocular hypertension and uveitis, we all know that 5% of the normal population is responsive to steroids, especially children. And the risk factors can be POAG, rheumatoid arthritis, diabetes, family history of glaucoma. 18 to 36% of the patient's steroid response develop in 2 to 6 weeks. In the nucleus of the normal trabecular cells are two glucocorticoid receptors like the alpha and the beta receptor. The alpha receptor produces the extracellular matrix and the beta receptor inhibits the alpha activity. So if there is an imbalance in these two receptors, it can affect the IOP levels. Steroids have been shown to upregulate the alpha receptors. So the molecular mechanisms, so there's increased deposition of GAGs, elastin, fibronectin, laminin, type 4 collagen, and these all lead to secondary increased production and decreased destruction because of inhibition of several trabecular meshwork matrix metalloproteinases. Release of hyaluronidase is inhibited, causing inhibition of mucopolysaccharide depolymerization. So there is swelling of the cells of the trabecular meshwork and there is inhibition of the trabecular outflow. There's inhibition of the phagocytic abilities of the TM cells. There is decreased PG levels, which following a decrease in uveoscleral outflow. And there have been some reports also about the myocilin cause glaucoma gene product, the myocilin or the TIGR being involved in these cases. So what are the mechanisms of angle closure in uveitic glaucoma? It can be acute angle closure, that is pupillary block, as seen in acute anterior uveitis, chronic JIA, HLA, B27, sarcoid, and granulomatous. Here, the pathophysiology is because of the inflammation, the cells of fibrin and protein, they cause posterior synechiae formation. This forms the iris bombay or pupillary block. So there are some non-pupillary angle closure causes like the VKH, the Vogt-Koyanagi-Harada syndrome, where actually there's forward rotation of the inflamed edematous ciliary body. Secondary chronic angle closure examples are like idiopathic uveitis and sarcoidosis. Inflammatory cells, fibrins, and proteins form adhesion between the iris and the trabecular meshwork. So broad-based pass, and this causes total closure of the angle. Now moving to the clinical features. When we do gonioscopy, we come across whether the angle is open or the closed. So if the angle is open, we can see we can look at the iris and we can see patches of iris atrophy, and we can decide whether it is a case of herpes. We can see heterochromia and decide whether there is FHI, or we can see pigment dispersion and decide whether it's a UGH syndrome or IOL malposition. If it is normal in adults, it can be Posner, or in children, it can be JIA. Here, this picture is showing NVA and also like features like hypopyon. There is a whole galaxy of findings as far as uveitic glaucoma is concerned, much beyond the scope of this presentation. Once the angle is closed, we have to, the patient is presenting with iris bombay. We can see that whether the patient has goniosynechiae, and the reasons can be sarcoid, toxo, and Besset, and we can do a UVM to rule out ciliary body rotation or choroidal detachment and suspect a VKH syndrome. So going to the diagnostic approach, IOP is often excessively elevated and only mild pre-perimetric changes may be there. We need to frequently do HVF to monitor closely any possible changes in the peripheral vision that could be indicative of progression. So what is the role of OCT in uveitic glaucoma? Uveitis is a confounding factor in the evaluation of the RNFL thickness. Media opacification impedes image acquisition. So we know there is a noticeable thickening of RNFL because of active uveitis and uveitic glaucoma. There's increased production of PG analogs and there's breakdown of the blood retinal barrier. After treatment of inflammatory activity, there is a decrease in retinal thickness and increased cupping and thinning of the RNFL. Therefore, normal measurements of RNFL thickness in uveitic patients, they must be interpreted with a degree of skepticism, especially in those with increased IOP. We should always do the screening for RNFL alteration related to glaucoma in uveitic patients during the quiescent periods only. As far as UBM and ASOCD is concerned, they help in the assessment of the angle when the cornea is not sufficiently clear. UBM will help us to rule out the mechanisms of angle closure glaucoma. Visualization of the ciliary body is valuable for the diagnosis and management of ocular hypotony, especially in patients with chronic uveitic glaucoma. We can also see in the ASOCD the position and the length of the drainage devices tubes or the filtering bleb. So management of the inflammatory process contributes to the control of IOP in most of the cases. Prompt and aggressive anti-inflammatory medication has a better clinical course of glaucoma. So here is just a brief overview. If the angle is closed and there is an iris Bombay, we should go for an iridotomy and steroids. If the IOP is normal, we can just monitor with anti-inflammatory therapy. If the IOP is increased, we should increase corticosteroids. And still, in cases of persistent increased IOP, we should decrease the steroids because a steroid response is happening. In these cases, we should go for steroid-sparing agents. And if it's normal, then we can just monitor. But if the IOP is high, then filtration surgery may be required. If the angle is open, we can just treat with corticosteroids and follow the same plan. So what are the challenges in management of uveitic glaucoma? Corneal opacity, as in sclerokeratitis, there will be a difficulty in gonio or optic disc measurement. If the patient is having small pupil or complicated cataract or opaque vitreous, there is difficulty in optic disc measurement. If there is chronic recurrent uveitis, we will have closure of the PIs that we do. There's failure of the GFS. The PGAs are contraindicated in these cases. In cases of pediatric uveitis, lack of history, asymptomatic, and late diagnosis occurs in such children. There's difficult examination. We often need to resort to EUA. Failure to control in uveitis leads to failure of surgical treatment. That is the most important thing to remember. As far as anti-glaucoma medications are concerned, pressure lowering effect of most of the agents is highly variable, but medical management is sufficient in most of the cases. Around 25 to 30% only will require surgical management or further management. First line remains the aqueous suppressants, the beta blockers, carbonic anhydrase inhibitors, and the alpha agonists. The prostaglandin receptor agonists increase the inflammation in small percentages, and they should be used in caution in patients with history of CME or herpetic keratouveitis. Efficacy of alpha-adrenergic agonists and PG agonists may be partially inhibited with concomitant NSAIDs. If there is granulomatous long-term use of apraclonidine and brimonidine, they may also have a reactionary anterior uveitic episode, and patients, this is generally occurring if the patients had a history of allergic reaction preceding and had not stopped the treatment after the episode. So one of the studies I came across about this new drug, Ripasudil, where they have studied the IOP lowering effects in uveitic glaucoma, exfoliation glaucoma, and steroid-induced. And they say that the anterior segment cell score was significantly decreased from baseline after Ripasudil treatment, suggesting a possible anti-inflammatory effect of Ripasudil in uveitis, in addition to the IOP lowering effects. So management of steroid-induced glaucoma, we have to reduce the steroid and go for the immunosuppressive agents, again, not in the scope of this presentation. TGF-beta2 is also being studied with good promise. Next, we have can move on to filtration surgery in cases of non-responders, TRAV with MMC, but we should remember that it is less effective. The most important and critical parameter is to maintain a normal inflammatory activity before, during, and after the time of surgery. But mostly the filtration surgery is not elective, so a pre-op regimen of topical or systemic steroids is must for such patients. And common complications are recurrent inflammation, hypotony. Factors that can cause surgical failures are 45 years age, male sex, eyes with non-granulomatous uveitis, and post-op inflammation. Success rate is only 54% after a 5-year interval. The glaucoma drainage surgeries, I just finished. They generally the last resort for such patients, but also a first choice for uveitic glaucoma in many patients, especially in JIA. If there's extensive pass, we can place the tube in the sulcus. If AGV has a unidirectional valve mechanism, so there is lower risk of immediate post-op hypotony. Here we can see in this picture the complications, possible complications. There's occlusion of the AGV tube by the fibrin. So last is the cyclodestructive procedures. The rate of hypotony, unfortunately, is quite high than other secondary glaucomas and remains the last resort. Thank you for your kind attention.
Thank you, Dr. Pallavi. So as per your presentation, I think your first preference would be a primary tube surgery. Is it true?
Actually, it is not like that. It varies from person to person depending upon the clinical experience and the expertise of the surgeon. For me, the first preference remains trabeculectomy, and AGV is the second choice only. In some of the literature review, it definitely, they have said that second, since it's such a resistant case of secondary glaucoma, the valve should be performed first.
So refractory uveitic glaucoma definitely is an indication for a primary tube surgery also. Would the panel like to comment on it? Dr. Ravi?
Yeah, I would agree with what Dr. Pallavi has said. Initially, the first surgical choice should be a trab itself. In fact, I would go for 2 trabs before I would attempt AGV. But in some cases, when you see that conjunctiva is really bad and chances of primary trab failure is there, we can go for AGV. The interesting thing about uveitic glaucomas is that AGV also can have multiple complications. I remember I had one case of AGV, primary AGV done in one eye, and the patient had complete total CD. When we do it AGV, next morning we are relaxed, okay, everything will be fine. Say even the pressure is not fully controlled, at least there won't be any complication as such. The AC will be well formed, something like a topical phaco. But in AGV, I remember both patients, this particular patient had both eyes, total choroidal detachment, kissing choroids on day 1, and we had tough time handling these cases. So these cases are basically difficult. Uveitic cases are basically difficult. We have to try to control the inflammation as much as possible, bring down the pressures before attempting either trab or valve surgeries. But my primary would be like trab itself. And if it doesn't work, say in two trabs, then I go for AGV. But in isolated cases where we are sure that the first trab also is not going to work because of excessive inflammation or conjunctiva being unhealthy, we can go for primary tube also in these cases.
So post-op CDs are a known complication of surgeries in uveitic glaucoma. So Dr. Manish, what surgical precautions do you take in such patients? What is recommended?
So basically, be careful about the amount and duration of mitomycin C what you are using for these sort of patients, especially in patients who have a little bit of scleral thinning. So in case you find that, and that may be another indication where I'd like to go on for a tube implant in case I find a lot of scleral thinning and I don't want to use a mitomycin C and I know that the risk of failure is high. That may be one of the things. As far as choroidals are concerned, it's very important that in case you have a pre-op intraocular pressures which are very high, you need to decompress the eye very slowly, take all preoperative measures to reduce the intraocular pressures to a certain level before you actually start entering the eye. When you enter the eye, have a gradual decompression, have a close follow-up, and keep, usually the choroidals and the inflammation have their own cycles. So in case you find those choroidals, you have to keep looking for it. Sometimes they're back into the periphery and you have to keep looking for it. You have to hike up your steroids or possibly put the patient on oral steroids also for a certain period of time to find out.
What's the significance of pre-placed sutures in such patients?
Yeah, you can pre-place sutures and because of the sudden decompression. So in case I find the pressure is very high, I at least place one of the sutures as a pre-placed suture so that I can close it off the occlusion.
Right. So another main challenge is the post-op flaring up of inflammation. So Dr. Swarnali, I would like to ask you, what is your regimen of steroid usage in such patients post-operatively? For how long do you continue this?
Initially, it's more frequent, the topical steroids I'm speaking of. And if there is any sign of choroidal effusion, like choroidal detachment, then definitely oral steroids. And it's usually 2 months, slow tapering of steroids, or topical steroids. It should be very slow tapering, and usually 2 months.
Right. So Dr. Pallavi, would you add an oral steroid just as a precaution, like in all post-op patients? Do you do that? Do you do a perioperative steroid cover? Can't hear you. You're muted.
Yes, generally in such cases, we manage this along with the UVR department. So we are giving routinely oral steroids to all such patients. 3 days we start preoperatively, depending on the body weight. The steroids are started, oral steroids, and then this is also continued. And after the surgery, depending upon the inflammation, how much inflammation is there, the oral steroids will be tapered. Like if the inflammation is too much, then it is continued at a higher dose. If it is reduced, if it is not much, then we can reduce the oral steroids. And of course, as Dr. Swarnali said, also topical steroids will be more frequent. But oral steroids we are giving routinely to all such patients. We are making sure that the inflammation is very much in control before doing this, because otherwise we can end up into a...
And what is your choice of cycloplegic?
Cycloplegic, generally we give homide.
Okay, right. Thank you, Dr. Pallavi. We'll move on to the last talk of the IC. So our next speaker is Dr. Manish Pandey, who's actually been my teacher at Shankar Nethralaya, Chennai. He has many awards and publications to his credit, and currently heads the Department of Glaucoma at Ratan Jyoti Nethralaya, Gwalior. He'll be speaking about post-PK and post-VR surgery glaucoma.
Thank you, IOS, and thank you, Richa, for the wonderful instruction course that you have designed. So I'll be talking about glaucoma secondary to PK and VR surgery. Am I audible clearly?
Yes, sir. Audible and seen.
Okay, thank you. So there are no financial disclosures. So these are the topics in which I'll be covering up my two parts of the talk. The first one is a post-PK glaucoma. Now, there are certain conditions which may predispose or have risk factors for developing these sort of glaucomas, which may include aphakic or pseudophakic bullous keratopathy, grafting and repeat grafting, a pre-existing glaucoma, that is a glaucoma that is there even before you try a PK, and in certain situations such as post-perforation, infective, ICE syndromes, and trauma. But these two things are very interrelated to each other. Penetrating keratoplasty in itself can cause glaucoma, and glaucoma in itself can cause a need for a repeat PK because of failure of the graft. So these two things are interrelated to each other. The incidence is quite high. It's around 9 to 35% with a high risk of graft failure with glaucoma. You can see that it increases from 11% to around 58% in case both medications and glaucoma surgery have been done in this study. What is the pathophysiology for this? A distortion of the angle with a collapse of the trabecular meshwork. So there is a whole collapse of the trabecular meshwork which can happen, and that causes a raised intraocular pressure. There are certain conditions which can cause it, including a suturing, which may be long bites, tight sutures, as you can see a large graft in the picture, inflammation, a very prolonged use of steroids, peripheral antiasynechia, and a pre-existing glaucoma, as I have discussed. But it's a challenge to measure the intraocular pressure after a PK because of the distortion, the astigmatism, the scarring, and the flattening of the cornea. So in case it is possible, you can do an apprehension tonometry. In case it is not, have a tonopen or an eye care. And sometimes what helps is the peripheral rim of the cornea. So in case you're not able to check it, you can possibly use the tonopen and check from the peripheral intact rim of the host cornea and try to see whether you can get some readings out of the tonopen. And document the angles in the optic nerve head whenever the condition permits, and keep in mind that epithelial and strobal edema may itself cause a falsely low IOP readings, especially in the initial postoperative phases. Medical management remains the same, except be a little more cautious in the use of carbonic anhydrase inhibitors because of the risk for corneal decompensation in these situations when you find that the cornea is already weak. Trabeculectomy and glaucoma drainage devices are the preferred surgery. Trabeculectomy is fraught with failures, and the glaucoma drainage devices have a high risk for graft failure if they are placed into the anterior chamber. So the other options, in case you are able to do it, is a placing into the pars plana or the sulcus. So I'll give you an example of a 69-year-old male that had a cataract surgery around 6 years back in both the eyes and came with a left eye deep stromal infiltrate with hypopyon and was planned for a therapeutic PK in the left eye. With initial spikes of pressures and 2 months pressures of 22 on 3 medications, finally at 4 months his pressures rose to 52 on maximum medications with astazolamide. Graft was clear at this point and he was planned for a tube into the sulcus in the left eye. This is a picture, and you can see the tube behind the iris there. This is a 3-year post-op picture, and the pressure is around 13 with a 618 vision and a clear graft, and the disc is healthy in these eyes. How it's not that easy in all these situations. This is another patient who has a decompensated sort of graft, and in this situation, I had to put up a tube into the sulcus. It's difficult to insert the tube into the correct plane, and it took a lot of effort to actually put this tube into a correct place in this surgery. Trabeculectomy is possible. However, we have to have a mobile conjunctiva. We have to use mitomycin C when you're doing trabeculectomy, have a deep anterior chamber, and there should be no the peripheral anterior syndicate of the graft host junction. There are certain issues including scarring at the limbus from previous surgeries, the PAs which may preclude a surgery, and a shallow anterior chamber may itself cause an endothelial cell loss after a PK is done. Sometimes it is possible to go for a sequential surgery. So this patient came with a road traffic accident and a spontaneous lens extrusion. And you can see a triradiate tear, and the patient underwent a primary repair. And after a few months, he started having his pressures were increasing and they were not under control, and underwent Anterior intraocular lens and Ahmed valve implant in the same sitting. And his pressures were okay, so around 12 on single medication. The vision improved to 624. The vision was less because of the central scar that was there. And he was fairly okay for the next couple of years. But finally, when his vision started dropping again, he underwent a penetrating keratoplasty. And his vision improved to 6/9 with the pressures of 14. You can't see the tube tip at this point in this picture because I have trimmed the tube during the PK surgery. And you can see a fairly well-functioning bleb. So IP control prior to a penetrating keratoplasty is what is necessary. Cyclodestruction may have its own role, but because of the increased risk of inflammation, hypotony, graft failure, and loss of vision, it is reserved for certain eyes. Therefore, in PK, a surgical treatment is tailored to an individual patient, and control of pre-existing glaucoma prior to any PK is what is important. Now, I come to my second part of my talk, which is post-VR surgery glaucoma. When you're talking about post-VR surgery, we may be talking about scleral buckles, pars plana vitrectomy, or intravitreal gas or oil injections. So once you are using a scleral buckle, it mainly causes a vortex vein compression, which causes a ciliary body edema and causing an anterior shift of the lens iris diaphragm, which may cause an angle closure glaucoma. Pars plana vitrectomy itself means it does not, without even a silicone oil or without any other procedures, only a plain pars plana vitrectomy may itself cause glaucoma because of an oxidative damage to the trabecular meshwork, which may happen in 15 to 20% because of the movement of the oxygen radicals and damaging the trabecular meshwork. In addition to PPV, injection of intravitreal gas and oil, especially oil, which may cause an increasing incidence of glaucoma with time, say it's around 2.2% at 6 months to 56% at 8 months. And that may also be a reason why you may have glaucoma developing after a VR surgery. But are these two things related to each other? Glaucoma and retinal detachment, are they actually related to each other, and why are they related? It's because both of them may be associated with myopia. So we know that glaucoma may be associated with myopia, and we know that retinal detachment may be associated with myopia. So some of the studies have actually found out a link between a glaucoma and a retinal detachment, even in patients who have not undergone a retinal detachment surgery. The pathophysiology may be different, and some of them have already been explained. It may include a not very well functioning trabecular meshwork after trauma. It may be a physical obstruction of the trabecular meshwork by means of oil or blood. It may be because of steroid-induced intraocular pressure rise. Maybe because of volume expansion, because of an overfilling. So sometimes your overzealous retina colleagues may overfill the silicone oil or the gas, and you have to forewarn them. Inflammation, which may cause a synechia and an angle closure, or sometimes the gas and the oil may actually push the iris and lens anteriorly, causing a pupillary block and obstruction of the trabecular meshwork. So we have to look into the pathophysiology. But whenever you're looking at a picture, don't miss the oil. That's what your retina colleagues are likely to do. So he has a pseudophakic patient, and you can see that oil shimmers there. And if you look closely, you'll be able to see the meniscus there as pointed by the red arrows. So sometimes these patients are sent up by the retina colleagues, and they'll say that retina is fully attached and everything's fine. The pressure is 50. You don't know what is the reason. You have to find out what is the reason, and you have to look at the reasons there. Sometimes they are very, very subtle. So in this case, there is a phakic patient, and you can see that even in this situation, there's a post-trauma eye, and you can see the silicone oil into the anterior chamber. But if you don't look at it carefully, this may actually be missed out. The post-silicone oil injection, because of the zonular weakness and there is some laxity there, the oil has actually seeped anteriorly and has caused a pupillary block in this situation. So the treatment depends on the cause. In case there is an overfill, we may need to remove the gas, have a gas tap, have a proper positioning of the patient, or possibly do a PI. In case it is required, we may need to do removal of the oil or surgical or a laser or surgical PI. So treatment is addressing the cause. What is the cause for that? In case there's an overfill of the gas, we may need to have a partial removal of the gas as told. Tight scleral buckle, we may need to loosen it, or we may require a partial removal of silicone oil from the anterior chamber in case there is an overfill and there is filling into the anterior chamber. In case of steroid-induced intraocular pressure rise, we may need to add the patients on anti-glaucoma medications. Medical treatment remains fairly the same. I'm not going into details, but be a little careful about prostaglandin analogs because of the risk avoid active inflammations or CMEs, and patients usually may require a short course of systemic acetazolamide. There are certain issues with trabeculectomy in these situations, and these include a conjunctival scarring from buccal. As you can see in the picture, a lot of scarring there and a lot of subconjunctival silicone oil there. A prior surgery such as vitrectomy and cataract surgery, anterior segment neovascularization, residual emulsified silicone oil, and chronic inflammation. So these are certain issues with trabeculectomy. Trabeculectomy can also be combined with silicone oil, but you know the success rates are limited, and you may need to resort to certain measures such as needlings and 5FU injections even after the surgery, because you know that these trabeculectomy is likely to fail and as compared to any other normal persons. So in certain situations, we may need to think about going for a tube implant, especially in case there is a scarring or there is a high risk of failure of your conventional trabeculectomy. There's an example of a 10-year-old boy with a microcornea, one-eyed, pressure is around 54, and because of the multiple ports, you can see all those staphylomas at all those ports which are coming out. Pressure is around 54, and with the advanced glaucoma, he's one-eyed. So at this point, it's not possible to do a trabeculectomy, conventional surgery, and therefore I resorted to do a Ahmed valve implant in this, and the valve was placed into the vitreous cavity through the pars plana, as you can see. And you can see that wiggling tip of the tube behind the iris when I'm trying to shake it. So this is the tube tip just behind the iris, which is showing a little wiggle there. So over a course of time, these staphylomas have come down. They are not resolved fully, but they have come down, and the pressure is around 12 with a vision of around 4/60 and a well-functioning lab. Ahmed valves can also be used inferiorly. This is a post-silicone oil removal, and there is still a lot of residual emulsified oil, and I resorted to an inferior valve in this situation. Post-buccal remains a challenge because, and you can see that the buckle, the belt buckle there, you can see with the red arrow, and it's quite anterior. So it's not possible for me to do a trabeculectomy here, and therefore I resorted to a valve implant. Valve was placed into the posterior cavity, and you can see the well-functioning bleb, and I've covered it with a corneal graft so that the cosmetic appearance appears a little better. So sometimes we can suture the valve also to the belt buckle in case you're not finding the space in that situation. Sometimes when the situation is very bad and you're not able to do anything, transscleral cyclophotocoagulation may be of use, but they are usually reserved for eyes with poor visual acuity because of the risk for hypotony and visual effects. But they are sometimes useful as an adjunct to functioning aquashunt. So sometimes just want the pressures to come down a little and there is no other way you can do it. So they may be used in certain eyes as a last resort. So glaucoma, we always show that whether it's a post-PKI or it's a post-VR surgery, glaucoma may actually be pre-existent. We may be noting it post-operatively, but may be pre-existent. And a pre-operative evaluation and surgical planning is a must for these complicated glaucomas, and always counsel on limitations for any of these surgeries. Thank you.
Thank you, sir. Thank you for taking up this very challenging topic. A few surgical challenges in silicone oil filled eyes can be oil migrating subconjunctivally in trap and it may be blocking the tube of the valve. So what are your thoughts on that?
Look, basically, you're talking about the subconjunctival oil, or it's oil in the antechamber?
Subconjunctivally, because that actually incites an inflammatory reaction, and the bleb eventually fails in these patients.
Yeah. So if I find too much of oil into the subconjunctival space, I would possibly go for a tube implant rather than doing a trabeculectomy at that point, because it's not possible to remove all that oil from the subconjunctival space. So find that what I pictured, that I showed, a lot of oil into the subconjunctival space. If I try to do a trabeculectomy, there's a high risk for failure there. So I would possibly go as a first choice towards a tube implant in case I find too much of oil into the subconjunctival space. I'm not saying that trabeculectomy cannot be done, but you have to balance which sort of surgery is likely to yield results for you.
Right, thank you. So we have an audience question by Dr. Asmita. So she's written, there's a case with intraocular pressure of 45 millimeters of mercury with pseudo exfoliation, corneal edema, AC cells are there, CCT is 650 in both the eyes. So is this uveitis or pseudo exfoliation glaucoma? Dr. Pallavi, would you like to take this up?
Yes. So since there's AC cells in such a patient, it more likely points towards a cause of uveitis. So you have to make sure you look at the anterior chamber properly, look at the other eye, take history, do a systemic evaluation, ask the patient about any other associated diseases. So more likely that it's an inflammatory cause, and you will find something. You can also take help of your uvea colleague if available at your institute.
Right, and she's asking, why is the CCT high without any corneal edema? Can the CCT be high without edema?
Yes, CCT is in the Indian population, it has been measured that it's somewhere around 520. That is a normal value for the Indians. But if you see, it is around 550 in the European or the Caucasian population. Not just this, but a lot of Indians will also, if you do, CCT is a must to do as far as glaucoma workup is concerned, should be doing, and you will come across many patients who are having normal CCT of 580, 590 or more than 600 plus also. So there's nothing as such. It's a part of workup. And then once it is what is the IOP that she mentioned?
45.
45.
45 is definitely not because of increased corneal thickness. This is most likely inflammatory glaucoma. And there is combined mechanism because of the pseudo exfoliation. So you have to look at everything, think about everything and combine. So these are, even though we have talked individually, all these cases can be combined. That is contributing to the glaucoma in such a patient.
Right. I think we'll need to wind up. We've come to the end of the session. I thank the speakers for sharing the pearls of wisdom, AIOS and Chairman Scientific Committee for planning this beautiful, wonderful virtual platform, the audio-visual coordinators, and the audience for joining us. I hope this session has been useful for you. Thank you so much. Bye. Take care.
Thank you. Thank you.
Thank you. Thanks a lot.
Thank you, doctor.
Thank you, everyone.